Okay, we got it.
Perfect. Well, good afternoon. Thank you for spending the next hour with us. I am Cassidy Avila with the Center for Optimizing Rural Health, also known as CORH, and I'm pleased to welcome you to this webinar on 2023 Hospital Professional Fee E&M Changes. The knowledgeable Jackie King with Arch Pro Coding will be our presenter today, but before I introduce her, just a couple of housekeeping things. We are recording the webinar, as you just saw, and we will be sharing a link to the recording as well as a copy of the slides with you in a follow-up email. So if you'll give us about 24 to 48 hours to get it posted, then you should receive an email from CORH. We will have time following the presentation for Q&A, but feel free to drop any questions that you have into the chat box during the presentation, and I will make sure Ms. King addresses them during Q&A. And I believe she will maybe give an update on CEUs, but there is the potential for one CEU credit or awarded for attending this live event. It is now my pleasure to introduce our speaker. Ms. Jackie King has worked in the healthcare field for over 30 years in both clinical and administrative positions at small, rural, and critical access and physician practices. Her prior roles include medical imaging technologist, quality management utilization analyst, health information management director, and clinical informatics director. Ms. King received a Master of Science degree in health informatics from the University of Illinois in Chicago in 2012, and in 2016 joined the Illinois Critical Access Hospital Network as HIM consultant in compliance and clinical informatics director for the Illinois Rural Community Care Organization, Accountable Care Organization in July 2022. Jackie joined Arch Pro in January 2019 and also serves as the Director of Critical Access Education for that organization. Her primary duties in both roles include providing education, sharing resources, promoting efficiency and best practices, and improving healthcare services for small, rural, and critical access hospitals and their rural communities across the country. Thank you so much, Jackie. I know you guys are all in good hands. I will turn it over to you now.
Thank you. So interestingly, I need to update I'm always telling you this, I need to update my information. In July of 2022, I branched out and flipped over to Arch Pro Coding and my own kind of deal with them. And I just pick up consulting work now for Illinois Critical Access Hospital, but I still work for both. It's just in a different capacity. So yeah, exciting stuff. Big changes, they do the big leap of faith, the whole COVID thing, but I enjoy it. And so I'm always happy to present to you guys. But other than that, that's spot on. So today we're going to talk to you about 2023 hospital professional fee E&M changes, which were big. So if you worked in the clinical side of the doctor office side, you felt this angst at about the beginning of 2021. It's not angst, it's a wonderful thing. And here we go, we get to do it in the hospital setting now. So that's what we're going to discuss today in our time together. This is me again, my name, my credentials, my email address, best place to find me, jking@archprocoding.com. If you do contact us on our Arch Pro Coding website, you will be routed to me if it's anything to do with Critical Access Hospital anyway. So I'm happy to be here. Few disclaimers. I'm trying to teach you in an hour's time about the fun and exciting changes that are happening now this year. Not intended to be providing you coding, billing, or legal advice. I'm not a lawyer. Your claims go out with your tax ID number, not mine. So verify everything before you make any changes or decisions within your four walls. The contents of this program are copyrighted for use of other folks by Arch Pro Coding. It's recommended again to verify all your code selection and check your billing rules because there's billing rules for CMS and then everybody else. So just be sure when you're submitting claims in your system that you're billing the correct code to the right payer. So for instance, the G code would go to Medicare and it would not necessarily go to Blue Cross Blue Shield. All code assignments must always, always, always be supported by the appropriate documentation in the health record. The documentation is the source of truth for the bills that you're selling out or sending out and asking for payment. And I'm going to do a lot of referencing to the lovely 2023 CPT professional during this presentation. This is owned and written by the American Medical Association. I'm using them for educational purposes only, and I do not claim any ownership. All rights are reserved. The AMA owns the book and everything inside the book. All right, moving on. I always like to start my discussions when we're talking about coding with documentation so that we understand the impact that that note has on the whole, really the whole revenue cycle. So this little infographic, if you've seen my presentations before, will be familiar, but let's just run through it real quick. The very top purple button, the patient is registered. Very important information, and it starts the ball rolling for the claim. So be sure your registration folks, your patient access people understand how important their job and all those points, clicks, and data entry are to your revenue cycle. Let them know that what they do, in the end, a lot of what they do ends up on the claim that's going out to the payer. Bring them into the fold, raise them up. Generally, they're entry level, but that doesn't mean they shouldn't be part of the team. So once that patient's registered and checked in, an encounter note is created. Could be starting off with an MA or a nurse and moving over to the provider, but once it's all documented correctly and done and signed, the note or it slides over to coding. It's ready to be coded. It goes to the coders. I like to call the coders the last line of defense. We check the documentation, the coding, is it ambiguous? Is it accurate? Once it leaves our eyesight and slides over to the claim, out the door it goes. So we are clinical documentation improvement specialists. We're auditors. We help our providers with lots of different things. So we're a team effort and we're kind of their A team. So we check for them so that everything that's going out with their name or their tax ID or their NPI is correct. So when the payer comes knocking, we can back it up with what's in the note. So once that code goes out the door, the provider is going to get credit for whatever services were billed on that claim. And then it's going to slide over to billing. And in the perfect world, we want it to go right out the door, right past the biller, clean as can be. Clean claims are the goal. It's never perfect. It's nirvana. But the more we can do on the front end to get that clean, the faster it is out the door. Then we get to this lovely gold pea-colored circle that talks about denials and appeals. That's what takes a lot of the time. Having to go back, having to understand what the payer is saying is wrong. Get that information into lay terms over to the coder who may have to contact the physician. So that is the time-consuming bubble. We want those bills as clean as we can get them to help those billers handle these denials and appeals. And then cost reporting is uber important in our rural health and our critical access hospital world because we get paid if you're a critical access hospital, a rural health clinic, or an FQHC. You get paid based off the cost it takes to take care of your Medicare beneficiaries in the prior cost reporting period. Everyone who bills Medicare has cost reporting, but ours is super important in our world because that's how we're getting reimbursed. Okay, so that tells you what the note does and where it flows into the world of the revenue cycle. So quick agenda. We're going to review 2021 revisions because when I go through and review those and give you that information, it's going to help you just digest the 2023 E&M changes. We'll talk about hospital, nursing facility, or home and prolonged services codes, and including in that hospital will be your inpatient, your OBS, and your emergency department. And then we're going to do a few exercises to calculate the E&M level with medical decision making. Those are the harder ones. Time is pretty gosh darn easy, but we'll go through the medical decision making. Okay, so that's the gist of it. This is our 2023 CPT book. The layout of the book starts with the introduction. I always tell everyone when you get your new book, go back through, read your introduction. The guidelines have changed. There's a whole lot of green font in there. The green means new. So get into your book, highlight things that maybe carry over from last year to this year that you really need highlighted, but you need to understand those guidelines. They are very different. They're very different than before, but they're very similar now to the office guidelines, which is so nice. I think when we're done here, you're going to be pretty excited. So E&M is the first part of the book. It starts with the 99 codes, and that's where we usually hang out, and that's what we're going to talk about today. And then the rest of the chapters are listed throughout the bullets on the slide. But that's where we're hanging out is in the E&M chapter today. Okay, so E&M, CPT, the AMA first published a CPT in 1966. But the E&M guidelines weren't introduced until 1992. And then they were revised, as you know, in 1995, 97, 2021, and now most recently in 2023. So 1992, interestingly enough, the E&M guidelines were based entirely on time. And that's about where we're heading right back into time or medical decision making. So we've come full circle. So in 1995, they started using counting body areas and or organ systems. And then in 97, they did a little bit more development, allowing counting of elements or bullets, so that specialties that are only maybe working in one organ system can were able to get higher E&M levels for their exams. Because they weren't doing multiple, but they were doing lots of bullets in one area. There were restrictions approved in 2019 that started in the 2020 fee schedule final rule, but the sweeping changes that started this boat floating were in January of 2021. And those changes are falling into 2023 now. The point behind all of these changes were reduction in documentation burden for doctors, qualified providers, eliminating note bloat and the need to redocument certain aspects of the record. So trying to relieve physician burnout. It's ridiculous to make people redocument something that's already in the record. And then encourage more time with the patients instead of me sitting here with my doctor and him looking over here the whole entire time, because all he's doing is typing because that's his job. He can have a conversation with me, capture the highlights, what medical decisions were made today, and or how much time did you spend with me all day today, and out the door you go. So it's a big deal. It's a really wonderful thing. And I'm excited to talk to you about it today. So only office or other E&M outpatient guidelines and rules took place in 2021, January 1st. Now this year, outpatient observation, inpatient emergency nursing facility are in effect now, January 1st, 2023. This is a nice little summary. A lot of these slides I borrowed from the AMA because they're beautiful and I'm not going to reinvent the wheel. So I'm just going to use them to teach you. This was a summary of the major revisions, and these will now apply except to the emergency department. It's going to be a nice thing. So this is a good graphic. There's still a medically appropriate history and or exam required in the code descriptor, but it doesn't have to be 5, body areas, 8 organ systems, 4 elements of history of present illness, a comprehensive review of systems, medically appropriate. So what am I telling you? You need to go back and talk to your medical staff or your HIM department or your risk management, and you decide at your organization what deems an exam and or history medically appropriate. How are we going to do that? It's hard if you've not gone through this to feel comfortable when you're not seeing that. It is a medically appropriate history and or exam. It could have no history or it could have no exam, and that makes us a little freaked out when we're coders, but it's okay. The point is what's going on with medical decision-making. So we go over to the red. You use medical decision-making or total time on the date of the encounter now. And then they got rid of 99201 because when we're looking at medical decision-making being your the way you choose, they both had straightforward medical decision-making. So we don't need 2 codes with that because so we got rid of 99201. And then there were specific guidelines to E&M for the office. And now those guidelines will go through more for the hospital side. Just another slide, medical decision-making or total time on the date of the encounter. Not total time spent face-to-face with the patient, folks. It's total time you spent on that patient's behalf on the date of the encounter. So lots of changes. There are a lot more ranges that are delineated, not typically time spent. It is start to finish. This is how much time. If you have this documented by the provider, you have your code, super easy. And then they made a 15-minute time period to be able to capture prolonged services instead of making you have to reach a 30-minute point because so over and above your level 5, when you hit that 15 minutes, exceeding that, it has to be 15 minutes. They're allowing you to bill for more than that. And this is all coming into the hospital side too, but this is how it started. In 2021, they were only applying to the doctor office visits or office or outpatient. No more face-to-face. We're kind of reviewing. The medical decision-making will go over a lot of that. The history and exam are no longer as pertinent. And auditors, when we're checking these E&M services as an auditor who's a coder or if you're the auditor for your department, be sure that the time isn't less than what your medical decision-making would be. It's super easy to say, oh, 60 minutes, boop, done, or 32 minutes. But if you read the medical decision-making, it's a higher level. Give the doctor the higher level. So I hate to have everybody just close their minds and go with time every time because you could be shortcutting your doctors, underbilling, what's really really going on. I've seen a ton of people with templates that are just putting total time spent on the day, and that's okay, because we want them to capture that. We want them to be thinking about that. But what are they doing? What decisions are they making? What things are they doing to take care of this patient? How many things are going on? Don't shortchange your doc and just stop looking at the medical decision making. That's my reminder. Okay. And then remember, if you are doing total time, it needs to be time spent on behalf of the patient by the doctor, not the nursing staff. Okay, so that's something that's included. In February of 21, there was an editorial panel update, which is still, it's got a lot of question and answers. And I'm going to click here and see if it'll take me out there. It's still fairly good. It's 11 pages long, and it talks and it gets into more detail about maybe some questions you might have about when this first flipped over and what does this mean about independent historian and this and that. So I left the slide in because I feel like you can see some information here. If you never have done this before, there's a little bit more information. And then deletion of the CPT code 99201 again, that went away because we have two codes with the same medical decision making. All right. So in your office, the very lowest code on a new patient or an established patient is a new 99202. Okay, so as in the office, now in the hospital, except for the ER, provider chooses whether their documentation is based on medical decision making or total time. They're likely to give you both. There's still 4 components of medical decision making. You have your straightforward, your low, your moderate, and your high, which will correlate to the CPT E&M for the area of service. And in those complexities, you'll have to get 2 out of 3 elements within the 3 columns to get to get a level, and you obviously use the highest 2 scoring elements. So this is the slide. This is the grid for the E&M office, okay? And we've got some new information that does not fit in this yet. I'm waiting for the AMA to release a new grid that will be pertinent with the left-hand side having hospital codes. There's parts and pieces in the presentation, but I do not have one yet from the AMA. I check every single day. As soon as I do, I will share it with the world, but they haven't created one yet. But in the office setting, you still got what they're trying to tell you. The medical decision-making is over here based on 2 out of 3 elements, 1, 2, 3. You have 3 columns. You must have 2 out of 3 in the same row to reach your level of medical decision-making, and then your code based on new or established. And then inside of each of these is the number and complexity of problems. Then you've got your how much data did you review, order, or analyze, and then your risk. So this grid is a little more, it's actually a lot more detailed and focused so that you're able to select your medical decision-making better. There's a link to this grid here. We're gonna pop out here so you can see it. It's a little bigger on this screen, hasn't changed. So I can't get you a new grid. I just keep going out to the AMA and looking for a grid. Sooner or later, they're gonna get us one. They're really good about that. Okay, so that's where that is. I kind of blew up the top row so you could see again that there are 3 elements, and I must get 2 of 3. And then it talks about, revising the grid. They took out words like mild and unclear things, and they've really made it much more clear. Okay, so one thing I want you to remember on this 3rd bullet, risk of complications or morbidity of a patient can now include social determinants of health, and reasons behind also why am I not admitting a patient or why am I not intervening. So social determinants of health can make you have a high risk. If you're going to tell me that this patient needs XYZ care and cannot make it there because they don't have transportation, they have a language barrier and don't understand what I'm trying to tell them, they don't have they don't have insurance, I'm fearful for the outcome for this patient because there are social determinants blocking outcomes, positive outcomes. That's absolutely important to be watching for. Doctors and nurses should be capturing that, and you as a coder can get the social determinants of health from any ancillary staff member that documents in that record, in that legal record that you're using. That's in there. So that is going to potentially cause a negative outcome. So be aware of that. That's new. And that continues. So this is a quick screen back in the old way. And this was the way we did it in the hospital side until this month. you had your codes across the top. You had to have 3 out of 3 key components on an initial hospital or an initial observation visit. And in this is the initial office visit. But so if I had an expanded problem focused exam or history, a detailed exam and low medical decision-making, I had to go backwards and code the lower, the straightforward for the code, because it's a initial hospital encounter. I had to have 3 of 3 components. I like to call this a 3-stall garage. And unless all 3 cars were parked in one garage, I have to move the cars over till all 3 hit. And that's how we got stuck with lower levels. And that's too bad. But then we got into the new way. So the new way is medical decision-making or time. So if I'm using this for medical decision-making because the doctor didn't give me time, I now have that same expanded problem-focused history, a detailed exam, and low medical decision-making. I can select my code based off only this low medical decision-making and give them a higher code. The same concept is coming over to the hospital side. You're getting rid of the 3 key components. Out the door, okay? Nice and exciting. So I blew this up again just so you could see it a little bit better. It's very small. So again, your problems addressed are going to be self-limited or minor, and I have some more of this in a different slide, but I want you to be able to see this. And remember, 99211 does not require medical decision-making in an office setting. We will discuss this sort of thing in the ER when we get to that slide. It's pretty interesting stuff. So let's blow up what self-limited or minor might be. And this is in either case. It runs its course, doesn't need treatment or follow-up. They probably shouldn't, in the emergency room setting or the hospital, probably shouldn't be here. Acute and uncomplicated, it's a short-term thing like allergic rhinitis or a short-term UTI that can run its course, low risk. Chronic, acutely worsening, poorly controlled. So if it's chronic with exacerbation, asthma, COPD, that's exacerbated to the point they need to be hospitalized. An undiagnosed new problem, and it's a new condition. We don't know. It could be high risk of mortality. It's not defined yet. And then chronic with severe exacerbation is different. It's either getting worse and it's acutely worse, or it's severely progressed. It needs treatment. It needs hospital care, or they're not going to make it through the night. So that's your chronic with severe exacerbation. So lots of little descriptors that can help you pick when you're going through that medical decision-making table. When you're looking for a problem, this is a nice one. It's a disease, a condition, an illness, injury, symptom, sign, finding, complaint, or other matter with or without a diagnosis being established at the time of the encounter. Because as we're placing patients in a hospital setting or even in the ER, we may not ever have a final actual diagnosis. We got them out of their acute phase and sent them home, and maybe they're following up with specialty doc. But that's what the problem is. If a problem is considered managed or addressed, you'll need to look for one that's evaluated or treated at the encounter. You know, comorbidities listed in the history, when you're doing the medical decision-making, they're not to be considered as problem or addressed or managed unless it's clearly addressed in the note. And then a test, imaging, lab, psychometric or physiologic data, or a lab panel. So if I'm doing a lipid panel, I know there's probably 4 components, but 1 test. Lipid panel, any panel is considered 1 unique test. If it's ordered and reviewed as part of the same encounter, it's counted once. You don't get to double dip if you ordered it and got your results back. That's one unique test, okay? This is just a blow up of the amount and or complexity of data to be reviewed and analyzed, and we'll get into more of that with the hospital codes. Medical decision-making for some more terms I want you to look at that were on that. External records are from an external physician or other qualified healthcare professionals, an external facility, or an external healthcare organization. You see there's ors in there. So you could be looking at records from one of your organization's docs, but it's not the doc that's seeing the patient today. That counts. So they don't have to not work at your organization to be considered an external record. So it can be not in the same group or practice or in a different specialty or subspecialty. So don't, oh, well, that guy's, you know, primary care doc at ABC hospital system and they're in the ER. Well, that's not the same doctor. I have an ER doc looking at a primary care physician's notes. That's an external physician. And then independent historian this is important. We see a lot of this in hospital setting, a parent, a guardian, a spouse, even a witness who can add to the story and tell the provider what happened. If the doctor's not able to get that from the patient, if the patient is unconscious, not with the program, maybe they're handicapped, maybe they're deaf, maybe they have a language barrier, but you can get that independent historian by having someone else help tell the doctor and the nursing staff what's going on with this patient and why are they here. And then independent interpretation is when there's a test that is actually billable from a CPT code that you'd be normally getting a report on, but the physician that's taking care of this patient at the time is giving their own independent interpretation. Many times you'll see this with an EKG because they get sent out to a cardiologist, but they're interpreting it in the note. I independently reviewed the EKG and found X, Y, and Z. You're going to give them credit for that independent interpretation of that EKG. That's the most common one I see. Good question, Tracy. So I will address, for example, if the provider mentions high blood pressure, but makes no medication change, is this considered a DRESS? If they're not making any treatment decisions, unless they are continuing the medication, in the hospital setting, ER, they may not do anything to that if it's not pertinent to what the question is, the complaint is, but in the hospital setting, they're likely going to continue to order their blood pressure medications. That would be ordering a medication that's a maintenance that they take every day. So I would call that addressed in that case. So it's case by case. So if I'm admitting a patient to observation or inpatient and putting in orders for medications, and this is what they take at home, they're not being admitted for hypertension, they're being admitted for CHF, but I'm telling you to give them their metformin, or not metformin, but metoprolol every day to keep their blood pressure down. That's addressing it. Hopefully that helps answer that question. It's a good question. Very good question. So yeah, case by case. And then here's your risk for the doctor side or the clinic side, but I have it blown up further down into the slide. So I'm going to keep moving. So we got a lot of slides and I want to be able to answer your questions. Coding by time, not typical time typically spent anymore. It is a specific number and we're going to go in a range of numbers. And it used to need to be total time spent, over half the time was spent counseling and coordinating care. None of that, that's out the window. Okay, that is out the window now for everyone. It's there when the selection is based on time and not medical decision-making. But again, don't just close your eyes to the medical decision-making part of this. It could definitely be more extensive in a higher E&M level than the time. It again, it's total provider time on the same calendar date. So when the clinics were thinking this through, how are we going to, we've ordered a throat culture. It was 9 o'clock in the morning. The patient went home. I didn't treat them yet because I'm not really sure there's strep going on. And at 4 p.m. I get the strep back and it's positive. So now either myself or my nurse has to order the prescription. Well, I'm going to order the prescription. My nurse may have to call the patient, explain to them that they have a positive strep, blah, 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 blah. But the time it takes me to go in, order that, tell the nurse what to do, review the labs, all that gets counted. So the note gets closed maybe at 9:30 in the morning, but I just did more work at the end of the day. How are you going to capture all that? Same scenario in the hospital setting. How are you going to build your templates to get into the doctor's space that if you're using time, it's all the whole entire calendar date. That's a lot when the patient's on the floor. So it's something you'll have to figure out how you're going to do that and get that captured. This is a lot of provider activities that are inclusive in the total time. Before you even see the patient, looking at results, maybe I have I'm an hospitalist and I have an observation patient. I'm now down reviewing the ER and the lab results up to this point when I've received this patient. I may have a separate history that I'm going to talk with the patient and or their caregiver about. Doing any type of exam or evaluation medically appropriate, talking to the family and the caregiver during or after, ordering the meds, going in the CPOE, testing procedures, communicating with maybe maybe the ER doc that sent me the patient, documenting all of the charting, that's included too. And then if I'm doing any care coordination, if I'm preparing them for something on a discharge set and you're not billing my time for 20 minutes of care coordination CCM that month, you can actually include that too. If the time I'm spent doing care coordination specific CCM activities is being captured and billed, Separately, you cannot include that in my total time for the date, and that's anywhere. So this is a quick snippet of the date ranges or the time ranges for the doctor office. So 15 to 29 minutes must be documented for a new patient. I got a 99202, and it goes on throughout the listing. I use this a lot when I'm auditing. It's just really fast. And these are just the two sets of codes, either the new patient, and then the next page is the established patient. Just want you to read one of them. It's an office E&M of a new patient with a medically appropriate history and/or exam, and this is straightforward medical decision-making. And then total time, 15 to 29 minutes on the date of the encounter. That's how they all look. That's how the established patients looked. All right, so we got through the review. Let's get into the guts of the rest of it. We've got a lot of changes, not a lot of new, but a lot of changes. So lots of changes in the set. I've talked to you about a lot of this already, but I wanted to have this in a separate spot so you could go back. A definition of major and minor surgery. People would say, well, it's minor if it's a 0 to 10 global. No, it's not. It is not necessarily, it's major or minor based on the medical decision-making and the risk that the physician puts in the note. So watch for that. ASAP, the American College of ED Physicians, has some good information on that, but the minor or major surgery with the risk factors that's how you're going to decide when you're picking that out. You cannot use time spent if you're doing other services that are separately reported. So if you're interpreting an EKG because you happen to be the cardiology doc and you also did you're going to get paid for that interp separately, and you're also doing an E&M, you have to carve that extra time out you're going to get paid for interpreting that EKG elsewhere. That's double dipping. We don't double dip. Travel, if you're traveling, or teaching that is general. If you're in a teaching hospital, it's general teaching and it's not specific to one patient. You can't charge that patient for general teaching. Okay, and then different things about analyzing a test. What's a unique test? What causes me to be talking to another provider? How am I documenting that for medical decision making? So this is an updated table, but it's only a snippet. So they have not given us the whole table yet. Two things that changed on the hospital side. You'll see they added under the number of problems, one stable acute illness and one acute uncomplicated illness or injury requiring hospital or observation level of care. That's been added to your low medical decision-making for hospital. And the rest is the same. And then moderate didn't change at all. And then for your high, it added over here in your risk, none of these changed. It added the word for decision regarding hospitalization or escalation of hospital level of care, because you could have an OBS patient that you decided to place as an inpatient. So that's high risk. And then parenteral controlled substances, that is not oral. So it's any substances generally that are not coming through the mouth that normally could be taken orally that are being put into the IV or in another method. So again, if you go out to the ASAP, there's a really good, I'm not going to get into the detail, but you can Google what is considered, what kind of drugs they would consider that, codeine, morphine, that sort of thing. That's high risk. High risk because they can cause reactions. They can cause patient to, go to sleep and not wake up, lots of things like that. Okay. All right. So here's a high level summary of the guidelines. We've deleted all the OBS codes. They're gone. There are no OBS codes. It's all smushed together. You're in the hospital or you're in the ER. Okay. And then merge them all together. And even your discharge OBS code is gone. So now you're just in the hospital, or you're in the ER, or you're in an outpatient office or E&M. We talked about total time now in all of the codes. It gives you a specific set of total time. Got rid of the 3 key components. It did keep the 3 codes for if you're admitted to and discharged the same day for OBS or inpatient care. Those codes are the same. 99234, 99235, 99236, with a little bit more guidelines about that. Now, an initial service it's sort of like your new and established patients, but in the hospital, it's an initial service that patient's not seeing that other doctor or anybody in their specialty during that same group during this first visit, during the stay. So if you're having a physician's extender, an APN nurse or PA working with the docs, they're considered the same specialty when they're doing that on behalf and extending that position as an inpatient. It's the same for all of inpatient services. And just keep in mind, if I'm doing an initial OBS and then I'm deciding to make them an initial inpatient, you no longer have two separate E&Ms because it's all smushed into one set of codes. So one code for an initial day in the hospital, whether they're in an inpatient or an observation setting. So even if a facility moves an OBS patient from an ER to med-surg, they leave the patient. Even if a facility moves an OBS, so they're in the ER, from the ER to med-surg, put them in a room. Okay, so that's the observation. That's confusing, but I hear what you're asking. There are no OBS codes. Observation is a status, not a physical location. You can have a patient in your ER, in your PACU, in OBS the whole time and never hit the floor. So if you have an order for observation, you start counting your facility hours immediately upon that order and all of the doctor's orders happening to the patient. And your professional services for that initial would start as an observation. If in the same date, maybe the same doc ends up placing them as an inpatient because 6 hours later, they realize there's a lot more going on. One code, total time spent for that date on that encounter, and or you can use medical decision-making. It's one code. ER is separate, and I'm going to talk about that, but it's a little confusing. So ER is separate. The AMA is saying you can bill an ER and you can bill an inpatient or OBS on the same day. However, CMS doesn't say that. So be careful with that. If they're admitted to hospital, great segue, inpatient or OBS in the course of another site of service, ER, SNF, office, the services in the initial site may be separately reported with a 25 to indicate that a significant separately identifiable E&M happened, but CMS isn't playing that game. CMS says one E&M per patient and doctor per date, but other payers may pick this up. So how you're going to know? You're going to have to check with your payers. Are they going to allow Dr. Smith to bill an ER with a 25 professional fee, a 99283, and then a 99221 also on the same date of service for the same patient? That's the guideline change. That's where you have to find out from your payers. CMS is not going to let that happen, so be careful with that. Just because it's in the AMA's book doesn't mean a payer has to follow it, okay? And CMS is the biggest payer, so others may follow CMS and not allow it, okay? Consultation. So obviously Medicare doesn't pay for consultations, but if you have a consult in anticipation of an admission or related to an admission, by another doc, and then that same doc, so Dr. Jones is an ear, nose, and throat doctor, and I'm doing a consultation, and I want this patient admitted. I'm going to tell Dr. Smith, the primary care, you need to admit this patient, the eardrum's going to rupture. I come then on site and do a consultation on site. I cannot bill an initial hospital visit code. I'm to bill a subsequent hospital code or a subsequent care code, even if it's first time on the first day this patient was admitted. So even if I did the consultation the day before, I still only bill a subsequent code for that. They're going to catch that if they have the notes and find that. That's different. So this one varies from face-to-face data service. This is saying in their rules, if you're doing this and it has to do with this admission, it goes on as a subsequent encounter consult or subsequent encounter hospital on that admission. It's kind of confusing, but let's see where they're going with that. All right, here are the new time stamps on your initial hospital inpatient or OBS codes. So initial hospital inpatient or observation care per day for the E&M of a patient, which requires a medically appropriate history and or exam and straightforward or low medical decision-making, okay? So you must meet for a 99221, you must have 40 minutes, 40 or more minutes. At 55 or more minutes, you've got a 99222, and at 75 or up to 90 minutes, you have a 99223. Once you hit that 90 minutes, there's a 99418 asking for more. I've done a 99223's amount of work, and then I did 15 more minutes or 30 minutes. I'm going to bill this 99418 for every full 15 minutes beyond the 75. CMS has its own prolonged service G code, so we'll get into those in a minute. Here's the subsequent, same deal. Subsequent hospital inpatient or OBS, everything's the same, except the minimum time is less. Only 25 minutes needed for a level 1, 35 for a 2, 50 for a 3. And then if you hit that 65, every full 15 minutes beyond, you have a prolonged services code, depending on your payer, whether it's a 99418 or it's a G code. And then these are the admit and discharge codes. The description is persons coming and going on the same date. And the minimum time spent all on that same date, preparing this patient for inpatient admission and discharge is 45 minutes. And it goes through the different numbers of times, okay? So has to happen on the same date. Let's talk a little bit more about this. I need to have, as an auditor, if I'm checking my chart, 2 or more encounters on the same date. I can't have one encounter and be charging these codes. We were very gray and vague on this. It's very clear now. If I do not have 2 or more separately discussed encounters, it could all be in one note, but I need to know that you saw this patient at 8 a.m. and again at 4 p.m. I need to have 2 separate, I would be pushing for 2 separate notes. That would make me feel better as a compliance person, okay? So 2 separate notes, that's distinguishing the admit part from the discharge part. And then I'm going to feel confident in billing either the total time or medical decision-making for one of these 3 codes. For a patient admitted and discharged at the same encounter, 1 note, 1 encounter, bill an initial hospital code. Very clear. All right, and again, CMS is trying to use the word calendar date as per day, same deal. If it's less than 8 hours, they're telling us to use a 99221, 2 or 3, an initial hospital code. This is kind of CMS-y, AMA-ish. Your payers may distinguish this differently, or Medicaid may have a fit about this. I don't know. If it's less than 8 hours, and even if you had 2 encounters, they're suggesting you do not bill this 99234 or 5 or 6 because you're asking for a lot more money for not so much work. Okay. And if it's 8 or more hours, but less than 24 hours, get this, even if it's on 2 dates, they want you to use the 99234, 5 or 6 on the last date. You may have payer issues with that. Some MACs won't allow the admit discharge on the same date code if it's different than the day the patient was placed in observation. So, but this is the AMA saying to do it this way. You're going to have to check with your payers. I can't ever give you a black and white, can I? All right, so this is discharge services now. Inpatient or OBS now, we need to know the time that they spent preparing this patient for discharge on the date of the encounter. 30 minutes or less is going to be the 99238, and more than 30 minutes on the date is going to be the 99239. So we didn't used to have them give us a time when they were leaving OBS. We need times now. And if they are truly taking more than 30 minutes, we want to be sure we're billing the 99239. This is a very underutilized code because we didn't have documentation that the physician spent over 30 minutes. So I always recommend, if you're having a template of sorts, don't say 30 minutes or less or more than 30 minutes, but leave a blank. Total time spent on the day of the encounter preparing this patient for discharge. And then if you have someone else that's helping discharge a patient, the parenthetical note says this is to be used by the doc who is responsible for the discharge services. If there's other folks helping too, they're just supposed to use a subsequent hospital encounter code. Only one doc should be using the discharge code, the main attending doc. Consultations, again, Medicare doesn't pay for consultations, but they are very similar. They did get rid of 99241 for office consultations and 99251 for inpatient consultations, because again, the bottom one said straightforward or low medical decision-making, so we don't need 2 codes with that. A little note that the CPT gave us is if a payer considers consultations, the inpatient OBS or office visit codes may be used for consult. You can use either one. Again, Medicare won't cover it. So something to keep in mind if you're billing consultations. The guidelines are all the same. So it's the 3 R's: request, render, and report still needs to be there. A patient asking for a second opinion not being ordered by a physician is not a consultation. All right, just a quick one there. All right, so your base code for a office or outpatient consultation, that is one that you can use. I would probably use the hospital one. I would think there'd be more RVUs there. Your time is there. And it talks about this is a new or established patient, and it has that medically appropriate history or exam, and it's got the straightforward medical decision making. And as you go up, 99243 would have low, 99244 would have moderate, 99245 would have high, and then also here's your total date, total time spent on the date. And again, remember, well, CMS doesn't take G codes, so never mind about that one. And then inpatient or OBS consultation, new or established, medically appropriate. Your times are a little higher. So if I go back one slide, you'll see I only need 20 minutes to bill it for the office code. I need 35 to bill it for the hospital code. That might be your differentiator. I would guess these have higher RVUs because the very minimum time is 35 minutes. You take that back to your consultings. All right, ED. There is still not an allowance for time for billing ER unless it's critical care. ER, E&M levels were not brought into the time fold. However, they did a lot of changes to the code descriptors so that the medical decision-making matches. They line up. They left the 992812345 because it was easier. A really great thing in this last bullet, current practice was not explicit in the CPT code set prior to this. You may use an ED E&M code, even if you're not the ED doc. If you come in and see your patient as in the ED, you can use a 99281, 2 or 3 or 4 or 5. It's not just for them. And then critical care may also be reported in addition to the ED service for clinical change. So that's different. That was be with the 25 modifier on the ED. Check with your payer, but they're saying that that's been delineated because they could be there for quite some time and you did a whole E&M workup that wasn't critical care time. And then they tanked, then they coded, and then starts my critical care time. So it's only fair that you did all this evaluation and management prior to the time they coded. You should be able to get paid for both. You've earned it. Again, one more time, one more review. Time is not a factor because we could be doing a lot of things and popping in and out of the room, of lots of different rooms at the same time. Over an extended period of time, there's no way to really capture that. If it's critical care, their time is focused specifically on that very critically ill or injured patient. That's a different ballgame. It's even still hard to capture that. So the new modified linear progression of MDM, you'll see your codes. Now, the previous ones are on the bottom and the new ones are on the top. Look at this. 99281 may not require the presence of a physician or otherwise qualified healthcare professional. So that's caused a lot of talk. So the guidelines say, wow, so if a person comes in and only sees a nurse and the doctor never sees them, I can bill a 99281 pro fee. Well, that's kind of what it looks like. I've talked to a lot of hospitals and most are looking at not billing that 99281 if the physician never sees the patient. Because CMS rules still require any service that you're billing professional fees to be incident to a professional doctor. So they say outpatient therapeutic services and supplies, including visits, must be furnished incident to a physician service and under the order of a physician. So a lot of the hospitals, I work in Illinois, are not billing a 99281 pro fee if the physician never sees the patient. So that there's a lot of information out there. That's what the general consensus in Illinois is not to be billing that. You're going to have to take that back, talk to your risk management, talk to your HIM medical staff and make that decision. So if you have a person who comes to the ER, nurse triages them, a patient never gets seen by the doc, are you going to bill that 99281 or leave it be? Any orders for outpatient testing can absolutely, or you can bill for the outpatient lab or x-rays because that's just an outpatient test. It's going to get signed off by a doc. But can you bill for an intervention that the nurse did without ever seeing the patient, wound cleansing, I don't know, some sort of standing order for an injection, anything in that sort, I would be careful. So that's the best I can give you on that. It's not, CMS isn't going to allow it anyway. I would be very cautious billing 99281 if I do not have a doctor seeing a patient, but it's there. It's there. So here are your code descriptors. You're advised. So ED for the E&M of a patient that may not require the presence of a physician or otherwise qualified healthcare person. You'll see there are no times listed in these code descriptors, just your E&M, medically appropriate history and or exam, and then straightforward, low, moderate, or high medical decision making. Okay. All right, nursing facility services. I'll buzz through these because this isn't specifically to hospitals, so I want to get through there. But basically, everything is realigned to match the hospitals and the doctor offices. So the one thing they did add to nursing facility, if you're billing for a doc that's going to a nursing facility, and if that means if they're in your swing bed and you're billing for them, there are one little set in that first column of number of and complexity of problems addressed. Multiple morbidities requiring intensive management is only for the MDM for a nursing facility, which is great because, man, that's a lot of times why a person's there is they have they're a train wreck, I guess you call it. There's multiple things going on, so that can get you a high level. And I think I had this on a screen too. No more 99318, that code is gone. The annual nursing facility assessment, you would just use that with one of the subsequent nursing facility care services if it's a subsequent from the very first time you saw them, or a G code. And then not all initial care codes have the words admission assessment anymore, that changed. And then use a subsequent visit code, subsequent nursing facility visit code when the principal physician team member performs care before the actual required comprehensive assessment. So if I had to send a PA in because I had a skin tear that needed to be evaluated, but I haven't got to the nursing home yet to do my comprehensive assessment, I'm going to have my PA bill a subsequent nursing code, and I'm going to come in and bill my initial because I'm doing all that comprehensive assessment. Remember that principal physician, the admitting, the attending, when you got two people coming in and doing initials in a nursing home, you may want to think about modifier AI that says, yes, I am the attending. And also here comes the gastroenterologist seeing this patient on the same day. I'm going to have both of us are going to send through an initial nursing facility E&M code, but I'm putting an AI on mine because I'm the attending. It just differentiates that patient provider relationship. This is that slide more expanding about only specific to medical decision-making for nursing facility care by the principal physician, the AI person. Multiple morbidities requiring intensive management, a set of conditions, syndromes, or functional impairments that are likely to require frequent med changes or treatment changes and or reevaluations. The patient is at a significant risk of worsening medical, including behavioral status, and a risk for readmission to a hospital. That about explains everybody that's in a nursing home, unless they live there, okay? So very nice that they've given that to our physicians to be able to get that higher level of care. I love that. Here are your code sets, your initials, your times. Remember that prolonged service, there's going to be a G code. Most of these folks are Medicare, not everybody, but keep that in mind. Here's your subsequent with your times and your G codes, okay? Code descriptor example, this one's a little interesting. This is some guidelines that's talking about discharge management codes. This does not say, this says they're to be used to report total duration of time spent by a physician for the final nursing facility discharge of a patient. I am not seeing anything about on the date. Okay, so it's a different setting and they can't always get there on the date. So anything spent final examination of the patient, blah, 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 instructions, time, discharge records, prescriptions. Time for this includes total time spent on that date, even if it's not continuous, but if they also require a face-to-face encounter with the patient that may be performed on a date prior to the date the patient leaves. So when you're picking the code, date of the discharge management face-to-face encounter, that's when we're gonna look at the time. So it's a little confusing. So nursing day discharge management, 30 minutes or less on the date of the encounter. They may go home tomorrow, but I did all my work on Tuesday. So I'm billing this 99315 based on what I did on Tuesday. I may have to do one or two other things tomorrow, but that's how the nature of the business is. So read the guidelines carefully on those discharge. Home and resident services, they got rid of all of the domiciliary or rest home codes, deleted, and merged them with the home visit codes. Yay. And got rid of 99434 because, again, low or straightforward medical decision making. They the definition of a home is already there: private residence, temporary lodging, short-term accommodation, a hotel, a cruise ship. Wish I was going on a cruise ship. These codes are used when the patient is at a home that is not licensed as an intermediate care facility for physicians with intellectual disabilities, or it could be a custodial care facility or a residential substance abuse treatment facility. So you use place of service, but now it's codified in the CPT code set. When coding based off time, you can't use travel time. How long did it take you to get on the helicopter to get out to the cruise ship? You don't get to count that. All right, here's your time again. Same thing, new patient. Here's where they're at. Here's the type of medical decision making. Here's your time. It's the order of a repetitive theme. Here is an established patient, total time, and your prolonged service codes. And always remember, there's a G code for it if it's Medicare. Prolonged service, we got rid of all of the direct patient contact prolonged services code, 993545567. Now you either use the 99417 if it's more like an office setting or home setting, or the 99418 if it's more of a nursing facility, inpatient, or OBS. So that's kind of that. 99358 and 99359 are for use on dates of any other time, not on the date of the encounter, and the G codes are there for the prolonged services. So this just reminds you of what was deleted. G codes, you cannot use the 99417 for psychotherapy codes. There's its own set of codes. Psychotherapy has time-based codes. If you're using something over and above the minimum or maximum time, look in that code set for those. Don't use the 99417 add-on code. And here is the add-on code. You must each 15 minutes, I want you to see that, whoops. So don't shortchange yourself, but you got to hit 15 minutes. So if you have 29 minutes, you got one add-on code. If you have 30 minutes, you have two add-on codes. And it's giving you the codes you would use. These are the doctor visit nursing facility type codes. You don't report it on other codes that are not. It's giving it right to you in the book and the guidelines. And anything less than 15 minutes, you don't will. You have to meet 15. And then inpatient or OBS prolonged service, again, it's telling you have to hit at least 15 minutes and list it separately, and everything's right there for you to know. Okay, so we're getting close. We hit the 1 o'clock hour. Oh my gosh, we did. All right, here's your G codes for prolonged services. Hospital, inpatient, or OBS prolonged service, each additional 15 minutes by the physician. G0316 tells you which codes to bill it with. G0317, nursing facility has its own add-on code, and then G0318, home or residence has its own add-on code. They all say each 15 minutes per each 15 minutes. This is a nice little slide off the Federal Register page that you can kind of look at and see, where am I seeing this patient? Which code do I apply to my Medicare patients, and the time to report those thresholds before I can add it up. It's kind of like the critical care little graph. You got your total time, you know, oh, I bill a 99233, a G0316, and then however many else. Couple practice examples. I'm looking at the chat box and I'm not seeing anything. So 3 quick examples. Person's assessment in a doctor visit, established patient has hypertension that's being controlled on a blood pressure med, and I'm going to refill it. And they have neuropathy under good control, going to refill a medication. And then the next slide is the number and complexity of problems addressed. Well, I had 2 stable chronic illnesses, so I have a moderate for that first column. The second column, I didn't order any tests, so I have no amount or complexity of data to be reviewed. And the third, my risks column, I did do prescription drug management, so that's a moderate. So I'm going to score this out. 2 of the 3 elements. I have 2 stable chronic conditions, no data reviewed, and medication management. I have a moderate complexity and a doctor visit. All right, and then the next one is an initial hospital inpatient. So I've got a type 2 diabetes with hyperglycemia, uncontrolled, with a blood glucose level of 650, newly diagnosed, beginning sliding scale insulin, blood glucose checks every 4 hours, 2 labs ordered, and a diabetic diet. Also, the patient has CHF, which is stable, but I'm going to order an EKG and a BNP now and prescribe they're continuing their furosemide on a daily basis. So now I really don't need to look at the number and complexity of problems addressed at the encounter because I've got data in the other two columns. I have tests of each unique test. I reviewed the blood glucose and I ordered each unique test. I ordered 4 different tests. So I have a moderate for data, unique tests. And then I did prescription drug management for both. I ordered sliding scale insulin. I maintained their current medication. So that's a moderate. And this is, let's get over to the scoring. So I have to still have 2 of 3 elements for medical decision making. Did not need to even look at what's going on with their number of problems. Reviewed 1 test and ordered 5 new tests, unique, different tests, gave a prescription management, ordered medications, moderate complexity. I've got a 99222 for my initial hospital visit. This is if I don't have total time. And or if I had total time, that would code out to a 99221. But I did all this work, coders, let's build a 99222, okay? And then lastly, an emergency room case, patient with foot and ankle pain. Basically, they've got a sprain to the left foot, did a couple of x-rays, over-the-counter medications. So I have an acute uncomplicated injury. I did order 2 x-rays, 2 unique x-rays, a foot and an ankle, 2 unique. And there was no risk. I didn't order any medications. There's low morbidity. So out of my 2 elements, I have a low complexity. So I have a 99283. Nothing for time. This will always be how you code your ERs, medical decision making. Put a quick slide up. We always like to talk about the bell curve for E&M utilization. We don't always want everybody to say 60 minutes and a straight line that's sitting there at 60 minutes. There's going to be low, a lot of middle, and some high. So we still want to see this bell curve. We want to see that their utilization pattern is specific to each individual patient, that we're not sitting here with copy and paste notes and everybody's billing a mid-level bill every time. That's a red flag for an auditor. So we don't want to see that. All right, these are some links. That's that new grid, E&M coding guideline changes. All of these are in here. If you've got your CPT book, there's a correction document for the E&M companion and also the errata and corrections for the actual CPT book here. So you can click on these links and find that. Let me just pull one out for you, but these are live links in your slides. This was just released not even a month ago. Talks about some mistakes that are in the book. You know, you publish a book, you're going to have mistakes. All right, so yes, anybody who signed up with their own email will get the link. If you are sitting in a room with somebody else, that person's going to want to give Cassidy their email so that we can get you the slides and your CEUs. So you're getting 1 CEU from the AAPC. ArchPro Coding will accept that, so will AHIMA. So you're going to get a certificate with an index number that's going to be an AAPC certificate. So again, if you want to get that, be sure that you email Cassidy, or you can email me, but whoever, so that we get that email to you specifically, like if you're in a room with other people. Okay, I don't want you to miss out on your CEU credits.
Great, thanks, Jackie. And we had one comment in the chat that says, how can we get contacted for the ER E&M grid once AMA releases it?
I would just recommend that you go to the AMA website and just watch. I actually sign up for, I'm not a member of the AMA, but you can sign up for news blasts and emails. And when they send out, let's say we've had a new CPT code for a new COVID vaccine and the administration, it just comes as an email. So I would probably watch that. There's really no way for me to do that. You can, ArchPro Coding has a Facebook page. When I get that, I will put a link on our Facebook page so you can join. You can find our Facebook page and hit the like on that. That's probably how I'm going to do it. So find us on Facebook. If you're not on Facebook, you can check our website. We'll probably, I don't know. It's kind of hard to do, but I am so excited to find it, but it's not there yet. I just checked last night, like 10 o'clock last night. It wasn't there. Hopefully that makes sense.
Perfect. I don't see, okay, so someone else asked, who do we email for the CE? I'm going to drop my email right now. Okay, so a couple of you asked about my email and I just included it. So feel free to email me. Jackie's email is on the screen. If you don't catch mine, you can always, grab hers. But just to save her the time and effort, if you'll try to email me, then I'll take care of it. And then you can expect to see an email from us in a couple of days, 1 to 2 days most likely, and we'll get all of the resources to you. And I also dropped in a link to a 60-second survey if you have just a moment. That helps us. And if there are no other comments, I think we'll go ahead and adjourn. Jackie, I appreciate it so much. Thank you for your time and expertise. We always love having you present for us. And I guess we will see you guys next month. Thanks for attending. Bye, everyone.
Bye.